All righty. Hello, everyone. Thank you so much for joining us today, for joining our informational and recruitment session for our MMRC Technical Assistance Partnership Opportunity. My name is Maddie Curry. I'm an enrolled member of the Blackfeet Nation and a public health program manager here at NCUI, or the National Council of Urban Indian Health. Joining me from the team are Tiffany Stark, who's also a program manager, and River Carroll, who's a communications associate. We're also honored to have you here today. And again, thank you so much for joining us. We kindly ask that you please place your name, organization, tribal affiliation, and your title into the chat box. In addition, we'll welcome any feedback you would like to provide about your webinar experience in our survey, which is posted in the chat box. So just some quick housekeeping. Before we dive into the session, just a few things to keep in mind. The session is being recorded. All of your mics have been muted unless otherwise directed. Your questions can be typed into the chat box, and we'll have a Q&A at the end of the session. So please mute your microphone when you're not speaking. Enter those comments or questions in the chat, and then we would love to have your video on. Feel free to turn it off if you're not comfortable with that, though. Next slide, please, River. So shown in our agenda, here we have we're going to have a brief overview of our what American Indian and Alaska Native maternal mortality is, what maternal mortality review committees are, and then we'll discuss the MMRCTA program at NCUI. So, and then after that, we'll have a Q&A session and just an overview of the opportunities and make sure we're all on the same page with these opportunities that are being shared today. Okay, so next slide, River. Thank you. So just a little bit about some background on NCUI, the National Council of Urban Health. We are a national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives living in urban areas. NCUI is the only national representative of the 41 Title V urban Indian organizations, or UIOs, under the Indian Health Service and the Indian Healthcare Improvement Act, or IKEA. NCUI strives to improve the health of over 70% of the American Indian and Alaska Native population that are living in urban areas supported by quality healthcare centers. Next slide, please. And then our CDC acknowledgement, we would also like to acknowledge that NCUI is proud to partner with the U.S. Centers for Disease Control and Prevention, the CDC, through our cooperative agreement OT 1802, strengthening public health systems through the national partnerships to improve and protect the nation's health. The CDC is an agency within the Department of Health and Human Services, and the contents of this program don't necessarily reflect the policies of the CDC, the HHS, or the federal government. Next slide. And then our content sensitivity acknowledgement, we also really want to recognize and take a moment to recognize that addressing maternal mortality, more specifically American Indian and Alaska Native maternal deaths, is an incredibly sensitive topic that might affect some participants today more than others. So if you find yourself impacted by today's discussion, please connect with your support networks or reach out to NCUI and we can provide you with healing resources. Next slide. Okay, and this is our project team for this project. We have a wonderful group of folks with us. So we're very grateful for their work. We have all sorts of folks from all sorts of backgrounds, from federal relations to public health to research to communications. So a really robust team ready to engage UIOs with maternal mortality review committees. Next slide. Okay, so now we're going to dive into some of the content. And I'll start off by setting a context of maternal mortality. So in order to understand our partnership opportunity, it's good to have the context of what the issue is that we're facing today. So next slide, please, River. And I'll start off with just some definitions. Again, I apologize if I sound redundant, but just some definitions before that we need to go over before we move ahead with the content. So when we refer to maternal mortality is defined as deaths that occurred within, during, or 42 days after pregnancy, and that death is related in some way to the pregnancy. So then we have pregnancy-related and pregnancy-associated deaths, and those are technically what MMRCs will look into, and we'll talk about that in a couple minutes. So we'll have pregnancy-related deaths is the death that is during or up to 1 year, 365 days after the pregnancy, with the cause of death being somehow related to the pregnancy. For example, suicide related to postpartum depression. And then pregnancy-associated deaths are a death that is and occurs within the same time frame, so during or up to 1 year after pregnancy, and then but this death is not necessarily related to the actual pregnancy. For example, a car accident. So you can see that among American Indian and Alaska Native cases that were reviewed by MMRCs within the 2017 to 2019 timeframe, 29.4% of those pregnancy-related deaths occurred between 42 and 365 days after birth. So it's right outside of the 42-day window that defines maternal mortality. So that smallest circle right in the middle of the slide. So a couple terms that we'll keep in mind, but usually when we refer to MMRCs, we're talking about pregnancy-related and pregnancy-associated deaths. Next slide, please, River. Okay, so now we'll put into some perspective the prevalence of American Indian and Alaska Native pregnancy-related deaths compared to other racial or ethnic groups within the United States. So this graph right here is pregnancy-related deaths from the CDC Pregnancy Mortality Surveillance System, PMSS. So this is up to 1 year postpartum mortalities. So we can see while the rate in general is high for maternal mortality and pregnancy-related deaths compared to other developed countries, it's clear that there are lots of disparities by race and ethnicity within the population. Those most affected being Black and American Indian and Alaska Native women, and then also non-Hispanic, Native Hawaiian, and other Pacific Islander folks. So the variability in the risk of death by race and ethnicity might be due to factors such as access to quality of care, prevalence of chronic diseases, structural racism, and implicit biases. So these ratios right now this is congregated for all states, for all of the 36 states that were reviewed with the MMRC and for all ages. But of course, this data varies between varies by age and by state. So this is the national. So we can see, again, according to this graph, for every 100,000 live documented non-Hispanic American Indian and Alaska Native births between 2017 and 2019, 32.0 would result as a pregnancy-related mortality. Again, this is double the rate for non-Hispanic white births in that same period. So additionally, this data only includes cases that were marked as American Indian and Alaska Native, and racial misclassification is another factor that might be affecting these results and the variances between. So racial misclassification is a huge issue within case identification among American Indian and Alaska Native deaths. It's the racial misclassification of the death certificates has been a documented problem, and the race, ethnicity, or tribal affiliation of an individual is often left up to the person completing the death certificate, so the funeral director, the medical examiner, and they don't always ask people for confirmation around their ethnicities or races or tribes, and so this leads to many Native people being misclassified as non-American Indian and Alaska Native. However, there's an alternative to this, the solution potentially, in that MMRCs, they do look at other information regarding an individual besides death records. However, some MMRCs only allow for a single race to be selected for an individual. Excuse me. Um, Additionally, last little fact is that maternal and infant mortality rates are one of the few rates that are actually increasing or getting worse in the United States. So this is something that needs abrupt attention. Okay, next slide, please. Okay, so this is looking at a data set from the CDC Erase MM program, which I'll talk a little bit more about later. But this data set tries to adjust for that racial misclassification that I just talked about of those pregnancy-related deaths by allowing multiple races being able to be ID'd for AIA individuals within this data set. But you can see that the reported case numbers are still very low. And when racial misclassification is adjusted for, those mortality rates for American Indians and Alaska Natives have been shown to actually increase. But for right now, let's focus on what this table can tell us and from the cases that it includes, which is the underlying causes of death for all American Indian and Alaska Native pregnancy-related mortality for the 36 MMRCs from 2017 to 2019. The highest condition with 31.8% of all cases were mental health conditions, which is inclusive of suicides, poisonings, overdoses, or substance use disorders. And then second highest was with almost 1 in 5 cases of maternal deaths being hemorrhages. And this also isn't specific to delivery, but this is inclusive of postpartum hemorrhages. So you can see that a lot of these causes are due to underlying causes, and these underlying causes are a symptom of broader underlying social and economic issues that are rooted in racism and discrimination. Next slide, please. Okay, so that was a lot of maternal mortality data. However, pregnancy-related deaths we've seen they are preventable. So a preventable pregnancy-related death is defined as a death considered preventable if the committee determines that there was at least some chance that death being averted by one or more reasonable changes to patient, community, provider, facility, and/or systems factors. Of all MMRC cases in 2017 to 2019, amongst all races, all cases, 84.2% of those deaths were preventable. Of all reviewed American Indian and Alaska Native cases, those deaths were proven to be 93.3% preventable. So that shows that there's room for improvement in terms of preventing these maternal deaths. So what we saw on the last slide demonstrated the available data of American Indian and Alaska Native pregnancy-related deaths in that specific MMRC data set. So roughly half of those pregnancy-related deaths for that data is from obstetric hemorrhages and mental health conditions. So this is important to note because those two conditions just on their own are largely considered to be fairly preventable. For example, obstetric hemorrhaging by active management of the third stage of labor to prevent that postpartum or hemorrhaging, as well as recognition and response to hemorrhaging. And then mental health conditions, increasing social support, behavioral and mental health treatment, and increasing insurance coverage. Those are preventable, or those are ways to prevent these deaths. We can also see that most deaths are occurring between a week and a year after delivery, which also indicates the need for increased initiatives to support follow-up care for mom and baby. And then lastly, MMRCs are a valuable resource in understanding pregnancy-related deaths and developing strategies to combat this issue. MMRCs help communities prioritize necessary interventions to combat maternal mortality. So next slide, please, River. Okay, so moving away from the context of American Indian and Alaska Native maternal mortality, we're now going into kind of defining what MMRCs are. Just a quick background overview of what maternal mortality review committees are. Quite a tongue twister. Next slide, River. Okay, so their purpose. Maternal mortality review committees are considered the gold standard in identifying and reviewing pregnancy-associated and pregnancy-related deaths by utilizing a multidisciplinary team for a comprehensive process in maternal death case reviews. MMRCs are critical tools in facilitating and understanding the drivers of maternal mortality and complications of pregnancy to better understand and address these disparities. This work is funded through the CDC and the Erase MM program that I mentioned earlier. That Erase MM stands for Enhancing Reviews and Surveillance to Eliminate Maternal Mortality. Next slide. Okay. MMRCs are extremely important because sorry, one second. Oh my gosh. Okay, just making sure. Okay, so MMRCs are extremely important because they create the opportunity to build a complete understanding of the mother's story and what led up to her death, or their death, excuse me. And by collecting as many information sources as possible, the goal is to reduce any misunderstandings, misclassifications, discrepancies that might occur in a more traditional and singular autopsy report. So to tell these stories, MMRCs also utilize extensive information sources, including autopsy reports, medical records, which, prenatal, primary, postnatal, pharmacy, ED, clinical, all of those, incarceration history or police reports, their WIC status and community programs, obituaries, emergency medical services, and then key informants, which are really important for the communities that we work with, which are can be family and friends. We all know that community is extremely important for Native folks. So next slide, please. Okay, so how does an MMRC actually work? I'm sure you've all been asking that. So they work by first identifying a maternal health or a maternal death case, excuse me. And then we kind of follow this circle, I guess, of patterns, and that okay, so first the case is identified, and then the case is selected for review, and then they abstract all relevant information utilizing the information sources that I just discussed on the previous slide, and then developing that narrative of what caused the death and the relevant circumstances that led up to the death. Along with all of the provided recommendations that would have prevented that death. And then they also then review the narrative and then document, analyze those recommendations, and finally implement and evaluate to ensure those recommendations are effective. There are also 6 key decisions that MMRCs must make for each death review, but the top 4 decisions are: number 1, was the death preventable? Number 2, what were the contributing factors to the death? Number 3, what are the recommendations and actions to address those contributing factors? And number 4, what is the anticipated impact of those actions if implemented? So lots of upstream prevention efforts. Next slide, please, River. Okay, so who can sit on an MMRC? Like we said, MMRCs are multidisciplinary review committees. So they are primarily comprised of medical professionals in the past, historically. However, MMRCs have since expanded to include a vast array of professionals and partners who engage and serve people during their pregnancy and postpartum period. So shifting to these multidisciplinary committees is essential for American Indian and Alaska Native maternal death review, as we know, because of the complex factors that go into pregnancy when you're a Native woman or a Native person, excuse me. Okay, so we can see that there's a bunch of folks who can sit on a MMRC, from all the way from public health professionals to patient advocates, social workers, doulas, midwives, nurses, and then any other relevant stakeholder who can speak to the advocacy for the mother. Okay, so next slide, please, River. Okay, so now here is an example of some recommendations that were made from the Washington State Maternal Mortality Review panel, I believe is what they call it. So these findings were from a 2019 report that reported on the maternal deaths in Washington state from 2014 to 2016. While these recommendations are not specific to natives or urban Indians, they are very solid upstream recommendations that account for minority health disparities. Specifically, the first recommendation, which is addressing social determinants of health, structural racism, provider biases, and other social inequities in priority populations. And then this 2019 report also found that 60% of the total cases, of the 100 total cases reviewed, were preventable. So next slide, please, River. Okay, so that was our overview of the context of Native American maternal mortality, and then we discussed what MMRCs are and their role in preventing maternal mortality. And so now I wanted to just briefly go over what NCUE has been doing so far, because we are now in year 2 of our project, and to provide a little bit more background on what this partnership opportunity is going to look like, it's essential that we talk about year 1. So most of us in the room know that UIOs provide unique access to quality healthcare and culturally comprehensive services for urban American Indian and Alaska Native people who don't live on or near a reservation. So the big question we wanted to ask is, where do UIOs fit into all of this, into this entire MMRC process? So in order to kind of understand that, we wanted to do some information gathering via a feedback assessment plan that was developed in collaboration with our CDC partners. And through those feedback assessment plan, we developed 4 distinct ways in collecting information around UIOs and their kind of level of interest, understanding, and also current engagement with their either state, local, or jurisdictional MMRC. So the first one of those feedback assessment plan methods were to host a virtual dialogue for our UIOs to understand the UIO awareness around maternal mortality and MMRCs. So some of you might have been there. This was hosted last February. Oh my gosh, we're coming up on a year of that. So yeah, that was a great virtual dialogue. We are planning to have another one in year 2, so keep an eye out for that. And then we also sent out a questionnaire to all 41 UIOs to gauge maternal health service capacities at UIOs and understand the UIOs' levels of interaction with their jurisdictional MMRCs, like I mentioned. And then we conducted key informant interviews with Oklahoma City Indian Center, Kansas City Indian Center, and South Dakota Urban Indian Health, to dive deeper into understanding barriers around UIOs engaging with MMRCs and to explore recommendations for further engagement. And through that, we discovered that there really is little to no engagement from MMRCs with UIOs. So that's something that needs to be improved and fixed. And then lastly, we also attended the CDC Maria user meeting in April to provide UIO knowledge, guidance, and considerations during those meeting discussions. And we will be attending that meeting. It's an annual meeting held every April, and we will be attending that again this year, hopefully with some partners to help us with this work. And then lastly, we also drafted some recommendations. So for increasing UIO representation and engagement with MMRCs. So next slide, River. Okay, so some of these drafted recommendations include UIO representatives should be someone who understands the values and the role of American Indian and Alaska Native cultural practices and ceremonies in the pregnancy, birthing, and postpartum periods. Compensation for time and travel to MMRC meetings. We know that Indian country requires a lot of travel, and so compensation would be greatly appreciated for folks who need to travel long distances. UIO MMRC representatives need to be emotionally supported in this work. I just gave a very brief, dry overview of what MMRCs are and how they fit into the context of American Indian and Alaska Native maternal mortality prevention. However, we can all kind of understand that this is extremely heavy and emotional work that can cause a huge emotional toll on committee members. So having that emotional support is essential to make sure that cases are being reviewed, avoiding burnout, and that the committee members are continuing to go back and be continuously engaged with this process. Additionally, MMRC should be considered committed to diverse representation, examining biases, and addressing underlying systemic issues. So that is kind of going into the point about the multidisciplinary aspect of things, rather than just having such a clinical focus of MMRCs and reviewing these cases, really diving into more of that multidisciplinary, the actual story of the mother or of the case of the individual, rather than just the clinical side of things. And then also finally, MMRC should include the presence of American Indian and Alaska Native protective factors in case abstraction. So cultural and traditional values, language, ceremony, all of those things, perhaps beginning a committee meeting with smudging rather than, just jumping right into reviewing cases. So things like that. And again, these are drafted. They will be finalized more with the work that we are trying to do within this year too. Next slide, please, River. Okay, so here we are into year two, which is why you are all here today. So year two, next steps from 2023 to 2024, we are hoping to continue engaging UIOs with MMRCs, continuing education, and also promoting awareness, ensuring that UIOs always have a seat at the table when discussing maternal mortality amongst American Indians and Alaska Natives, because UIOs do provide so much healthcare to urban Indians as well. So please scan this QR code if you're interested. It's a partnership opportunity, and it's called the NCUI MMRC Urban Indian Maternal Health Alliance. Up to 2 UIOs will receive up to $12,000 each for the purpose of connecting and engaging with their state or jurisdictional MMRC, assessing those barriers and recommendations for increasing UIO engagement with MMRC, so some of those recommendations that I just talked about, and then also developing plans for continued engagement post-funding. So we want to be able to ensure that this work is continuing, and MMRCs are continuing to stay engaged with UIOs outside of project periods. Okay, so next slide, please. So the core requirements, the application deadline is December 31st, 2023, so about 2.5 weeks from now. I apologize that it's over the holiday, but the core requirements are, number one, designating a staff as project coordinator with commitment to fulfilling all of the project requirements and engaging with the MMRCs, attending monthly check-in calls with NCUI project staff and partners, and also mandatory participation in our virtual dialogue, which will be hosted in the spring of 2024, which I mentioned previously, and then attending up to 2 national or regional convenings with the NCUI MMRC team, including the 2024 Maria user meeting, which will actually be held on April 10th to 11th, 2024. So if you are an accepted partner, you can block that calendar, block those dates on your calendar off for a travel opportunity to Atlanta. And then also provide documentation of completed activities with a timely manner as agreed upon by NCUI and the UIO partner. This project period will end July 31st, 2024. And again, this is really the meat of the work will be engaging with your UIO's local or state or jurisdictional MMRC, as well as providing that essential UIO knowledge around maternal health and maternal mortality prevention services. Again, ensuring that UIOs always consistently have a seat at the MMRC table. And so it's really a lot of conversation and a lot of, conversing with a lot of other folks who are interested in maternal mortality prevention as well, specifically, those multidisciplinary experts. So again, it's up to 2 UIOs will receive up to $12,000 each to engage with their local or jurisdictional MMRC, as well as participate in any additional requested TA activities that are requested by the UIO as they relate to maternal mortality prevention. Next slide. Okay, so that's it. The floor is now open for any questions or comments you might have about today's presentation. Please feel free to turn your cameras on and come off mute or place those questions in the chat box. I will keep an eye on the chat. And then I will also place the JotForm link for the application. There you are. Okay, perfect. Thank you, River.
With the Bakersfield American Indian Health Project. I just have one question. And thank you for that presentation. It was, I really enjoyed it because we are trying to kick off some of these services for our community of natives here in Kern County in California. My question is, in the grant award, what say you have 50 applicants, what will be the process for determining, are you guys gonna have a panel that's gonna review each application? I'm just curious as to how.
Yeah, absolutely. Right. Apologies for not going through that process super detailed, but yes, we will have a review panel. Our wonderful project team, who I went over at the beginning of this, will participate in that. And then there are some specific maternal health related questions within the application. So just fill those out to the best of your ability. And then we will select based on, kind of the needs of the UIO and how they best fit into this project. And then any additional, requests or anything you have around, increasing those maternal health services or anything like that, you can always submit a TA request to us as well. And we'd be more than happy to help in that way too. But yeah, I'm looking forward to your application, Angel. Thank you.
Thank you.
Sure.
This is Carrie from Native American Lifelines. And I just want to say that, yeah, I'm glad this is happening. I know that for our Boston program, some of the hospitals and universities have wanted to work with us around this issue. And I think here in Baltimore, just around this issue, as well as issues of HIV or opioid overdose, it's really important to have a seat at the table because our people are not being counted, not in opioid overdose, not in HIV, and not, I am sure, maternal mortality numbers, because data collection, I mean, there's just no fidelity in data collection in our area. So I really hope, I'm definitely going to strongly encourage our team to apply, but I hope that other will as well, especially if your numbers aren't being counted. Having a seat at the table is the best way to make that happen and really lobby for Native inclusion in this data collection and pointing out when it's not happening, and really kind of forcing change.
Absolutely. Thank you so much, Carrie. I completely agree. Each UIO is unique in the patient populations they serve and all of that. However, we do have our commonalities within, that data misclassification and all of those things as well. So essential conversations that need to continue. Okay. Any other questions from folks? Yes, Tracy, this will be sent out with via email. I will send a thank you email and a follow-up. And then we will also make sure to post this partnership opportunity within our communications, our social media channels, Twitter, LinkedIn, Instagram. So look out for a post as well if you need one. Okay, if you don't have any other questions about the partnership opportunity or anything I just presented about, if anything comes up later, please feel free to send me an email. My email was just right there, but I will go again and put it in the chat. Sorry, thanks, Trevor. Okay, typing is hard. Sorry. Alrighty, so yeah, anything you need, please feel free to send me an email or anything like that. And again, I look forward to your reviewing your applications. Okay, so next slide, River. All right, so then we just have our upcoming events. Tomorrow we have a fireside chat in partnership with Pfizer on our health equity in action. And then on the 19th of December, our registration closes for our mental health first aid for UIOs training on January 19th. So if you're interested in being certified in mental health first aid training, please feel free to sign up for that. We would love to have you attend. And then again, in January, that's when that mental health first aid training will take place on the 19th. Again, if you have any questions, please feel free to reach out to me. Thank you so much for joining this important session. Any feedback you'd like to provide about the webinar experience, please do not hesitate to contact me. And then next slide, River. And then please do not hesitate to fill out our post-event evaluation form. This is essential to us and to let us know how you can improve or how we can improve our events moving forward. So please go ahead and fill that out as well. Again, do not hesitate to reach out if you have any questions for me. So I will leave it open we'll leave this room open for about 5 more minutes. And if you have any questions, please feel free to stay on and ask me. But if not, thank you so much. And I hope you have a great rest of your day. Thank you.
Great job, Maddie and River.
Go, Maddie.
We can do our debrief if you want, River.
Yeah, for sure. Let's see. Let me stop the recording.
Oops.